Okay, I'm going to give everyone just a few minutes to get in and before we get going here. All right, good morning, everyone. Thank you all for joining us today. On behalf of the Sparkman Center for Global Health, I just want to say thank you. This is our last seminar in our spring/summer series, Stigma and Health Among Refugees in Istanbul, Turkey. Just a few reminders today about our webinar tools that you can use. The session is being recorded and will be posted on the Sparkman Center YouTube page for viewing after the session. There is a Q&A box in the bottom, so please utilize that for questions if you have any. We will leave about 10 minutes at the end for questions, but feel free to write your questions at any time. And also there are closed captions available, so to access those, just click on the closed caption button at the bottom of the screen. And now I'm going to turn it over to our Sparkman Center Director, Dr. Bulent Turan. She is going to introduce today's speakers.
Hi, everybody, and thank you so much for joining us. I'm going to introduce Dr. Bulent Turan, and then I'll leave it to him to introduce his team members. So Dr. Bulent Turan is a professor at Koç University in the Department of Psychology. He is also a faculty member at UAB and continues to retain an appointment there. He is a social psychologist. He was trained at Stanford University, where he obtained his doctoral degree, and then he also did a postdoctoral fellowship at UCSF in health psychology. And I think if you search on his publications, you'll see that he's a leading and one of the most productive researchers in the study of stigma and discrimination. And a lot of that work has focused on HIV-related stigma, but now he's really broadening his research program and looking at a lot of other types of stigma and discrimination related to different identities and conditions. And in fact, he is going to be forming a Center for Stigma Studies at Koç University. So we're very excited to have him here and very happy that him and the team, and also happy that the Sparkman Center could contribute a little bit to this program of research through a pilot grant last year. Thank you.
Okay, speaking of said team, okay, so İbrahim Yiğit he was actually a postdoctoral fellow at UAB a couple of years ago. He is now an assistant professor in the Department of Psychology in Turkey. And Gulsah Kurt is a PhD student still, but next month she will not be because she is finishing up and she already has a job at a university as an assistant professor here in Istanbul, Turkey. And we worked a lot on this project, and we are excited to tell you more about it, starting with Gulsah's presentation on the background of the project.
Can you see my screen?
Looks great, yeah.
Okay. Thank you very much for the introduction, and thank you very much for everyone joining us today. And we are really excited to share the project focusing on stigma and health among refugees living in Istanbul, Turkey. As Dr. Turan said, I will provide you a brief contextual information about the refugee status and the mental health in Turkey. First, I would like to start with the recent statistics. As you know, violence, persecution, economic and the political upheavals have led to unprecedented increase in the number of forcibly displaced people. Now, more than 91 million people are forcibly displaced due to the conflict and violence at their home country. And as of 2021, 26 million are refugees who sought refuge in the hope for like safety and security in other countries. And among the largest group of refugees, we see Syrians and Afghans. And Turkey has become the transit and the destination country to millions of people over the decades. And now Turkey hosts the largest number of refugees with 4 million, including Syrians with 3.7 million and Afghans as the second largest asylum-seeking group in Turkey. And the majority of the asylum seekers and the refugees live in Istanbul as the metropolitan capital of Turkey. And there are certain characteristics differentiating the refugees from the immigrants. Refugees are forced to leave their country due to the fear of persecution and death, and they encounter several traumatic experiences either in their home country or en route to the host countries. And these traumatic experiences include captivation, witnessing death and the injury of the loved ones, being close to death, and many others. And their plight is not confined to their pre-settlement experiences, and they face several displacement-related stressors when they arrive to host countries. And these post-displacement stressors touch upon the different facets of life, such as like economic problems, discrimination, social isolation, and adaptation difficulties. As you know, like when they arrive to hosting countries, they are expected to adapt to norms, values, behaviors, and the cultures of the host countries, which compounds the existing difficulties and thereby increase the risk of developing mental health problems. And discrimination and the social isolation are the main contributing factors for these difficulties. Given that several risk factors play an intricate role in explaining mental health difficulties among refugee groups, predominant conceptual framework actually considers three different risk factors to explain mental health difficulties. These are pre-migration experiences, peri-migration experiences, and post-migration experiences. Pre-migration experiences actually refers to the biopsychosocial risk factors, increasing the susceptibility of someone to the adverse impact of displacement. Peri-migration risk factors refer to the exposure to war and violence, and actually conflict and war-related traumatic experiences. On the other hand, post-migration experiences refer to the constellation of wide range of difficulties, stressors that they experience when they arrive to host countries. And these include like complex asylum seeking procedures, employment, as I said earlier, stigmatization. So when we look at the prevalence of mental health problems among the refugees in the epidemiological studies, we see that they experience higher risk of mental health problems than the general population. And the recent estimates of the World Health Organization for common mental health disorders are quite high for refugees. And in addition to the common mental health problems, we see that refugees also suffer from some other conditions, such as prolonged grief disorder resulted from the tragic loss of someone that they love. And they also at high risk of developing schizophrenia and other non-psychotic disorders compared to immigrants who actually choose to migrate or leave their country. On the other hand, we see the lower use of alcohol and substance use and the lower suicide rates, which might be potentially explained by religiosity or any other cultural factors. In addition to actually the recent estimates for WHO, we see that in the recent studies, prevalence of depression, PTSD, and anxiety are quite higher than the prevalence estimates. And when we look at the prevalence of mental health problems among Syrians, it is similar to the prevalent figures in the refugee literature, but the prevalence rates actually quite vary depending on the methodology of the studies. But again, we see that they are at higher risk of mental health problems than the general population. Although the provision of mental health services are available to Syrian refugees in neighboring and Western countries, the number of Syrians who utilize the mental health services is quite low. Actually, it is less than 10%. And this underutilization refers to the major treatment gap, and it is explained by several factors such as treatment costs, lack of available staff, and lack of available language services to translate during the service utilization, and fear of stigmatization because they are seeking help for their psychological problems, and trust issues, mostly based on privacy. So based on these, actually the prevalence of mental health problems and the underutilization of the mental health services, in this particular project, we wanted to understand one of the main drivers of these health problems. So from now on, Dr. Turan will continue with the content of the project. And I will stop sharing my screen.
Okay. Okay, can you see my screen now? Good. Okay, so there is a paucity of research on the predictors as well as consequences of stigma due to being refugee globally, and especially for Syrian and other refugee groups in Turkey. There are some studies internationally, globally, but most of them focus only on one dimension of stigma. And as I will talk about, we want to focus on different dimensions of stigma, but so far perceived discrimination has been examined only. And by the way, this issue of stigma due to living as a refugee and its effects on mental health is actually getting worse during the pandemic. So what we wanted to do, our aims were to unpack the role of stigmatization in mental health, as well as service use, health service use among Syrian refugees in Istanbul, Turkey. So we wanted and we did develop multi-item scales to assess different dimensions that I will talk about in a moment of stigma related to living as a refugee. And then using these scales, we want to examine longitudinal associations of these different stigma dimensions with mental health, as well as health service use for mental health, as well as physical health. So we use this conceptual framework that we had developed for stigma related to other conditions and identities, and adapted it to stigma living as a refugee. And as you can see, the most important for us as a starting point is that stigma related to living as a refugee, we hypothesized will have different subdomains, dimensions. So enacted or experienced stigma refers to actual experiences of discrimination, devaluation, and prejudice and negative attitudes by others. Perceived community stigma is the perceptions of a person, the degree to which stigmatizing attitudes exist in the community, whether the person believes it or not. Anticipated stigma is expecting that others will treat one negatively in the future because of one's stigmatized condition or identity. And internalized stigma is when people with a stigmatized condition or identity accept negative attitudes in the community and apply these negative attitudes and assumptions about themselves to themselves. And so we want to examine the effects of these 4 dimensions of stigma on health service use and health outcomes, mediated by these different mechanisms, including interpersonal factors, such as social support, for example, psychological resources like self-efficacy or resilience, mental health, depression, which is also stress processes. So these will have effects on health service use, which then will end up with negative health outcomes as our conceptual framework. So to do this, we first wanted to develop these measurement tools. To do that, we first did an extensive literature review, and we searched for all of anything we could find in terms of research papers on refugees or immigrants or migrants or displaced populations. And we found hundreds of sources and then looked at them carefully and eliminated irrelevant ones. So we ended up with 27 of those. We also consulted experts, and with all of this work, we ended up with 77 items, which we thought tap into these 4 dimensions of stigma related to living as a refugee. So again, these are the 4 dimensions of stigma. So for example, and I'll give you some examples of items that we came up with. For experience stigma, a sample item is people made fun of me due to being a refugee. So these are, remember, experience stigma refers to actual acts of discrimination. So these could be blatant acts of discrimination, but they could also be more subtle. So I was denied opportunities in the workplace is a blatant type of discrimination. But making fun or treating badly in actually this is another one. The experience stigma also may differ by source as to who is doing the stigmatizing action. And stigma and discrimination in healthcare settings themselves are particularly detrimental to health, we found in the case of other stigmas. So I was treated badly by doctors and nurses in healthcare settings because I'm a refugee, reflects that. How about community stigma? So remember, this refers to perceptions of stigmatizing attitudes in the community. An example is most people seem uncomfortable with me. Most people view refugees as morally weak. Most people believe that refugees can't achieve much in life. And for anticipated stigma, people will look down on me because I'm a refugee. And lastly, internalized stigma. This is when people internalize these stigmatizing assumptions and they apply these to themselves. I feel ashamed of being a refugee. I think less of myself because I'm a refugee, or being a refugee makes me feel that it is my fault. So so what we have done is then these scales for the 4 dimensions, we translated them into Arabic. By experienced translators did that. And then we back translated them into English, and we compared the original English versions of these, the wording, with the back translations. And then we resolved discrepancies and worked on them to finalize the wording of the items. So next, due to COVID, we could not get to the next step, but we are actually, not that COVID is really disappearing in Turkey, although I'm sure it will come back again. But this summer, we want to first test these items that we created to ensure that they are appropriate with the target group. So what we want to do is we want to interview key informants as well as Syrian refugees, basically to ask them what they think about the wording. Do they suggest any changes? So ask them to evaluate the items, which will help us with this feedback. We will revise the items and finalize the wording of the new stigma scales related to living as a refugee. Now, what we want to do then is in a longitudinal study design, test the associations that these 4 stigma dimensions have with, first with mental health, and then health service use. And this health service use is both for mental health problems, but as well as for other physical health problems. And on the left here, you see our outcomes and our measures for these outcomes. So depression is a very important outcome for us, but we will also look at anxiety, PTSD, somatic symptoms, etc. And as I said, health service use. So again, our goal is to examine the associations that these different dimensions of stigma have with mental health and health service use. Now, we also want to examine mediating mechanisms in these associations. So some of the mediating mechanisms will be, for example, contact experiences, etc. Now, I think this is blocking. Okay. Now, lastly, we also want to examine the joint effects, the combined effects of stigma due to being a refugee, stigma due to mental health problems, and stigma due to poverty, using an intersectional approach. So our original plan was to include 300 Syrian refugees, although we are revising this actually, and I'll talk about the revisions in a moment, in 2 districts in Turkey. And these 2 districts, neighborhoods, have community centers that provide services for refugees. And we will use and collaborate with these centers to reach these populations. And we will have native Arabic speakers who will do the interviews to administer these scales at a convenient time and date for them. And the centers will provide private rooms for us to conduct these interviews. I say interviews, but these are administering these quantitative measures. And of course, these will be in Arabic. And our team in Turkey, which is headed by Gulsah here, says that because they have been doing studies like this, they say we can collect all of these data in 2 months tops, based on their previous experience. Now, let's talk about, so during COVID, we couldn't really start this project. So we said, well, look at something else, which is, as Gulsah calls, the other side of stigmatization. So that is, our main project is with the stigmatized population of Syrian refugees. But stigma starts with the stigmatizers. So in this case, not Syrian refugees, but Turkish people in the community who have stigmatizing attitudes against Syrian refugees here in Turkey. So we wanted to examine the other side of stigmatization and look at the Turkish people and their stigmatizing negative attitudes against Syrian refugees. So we wanted to understand the predictors as well as consequences of stigmatization among Turkish people towards Syrian refugees living in Turkey. And we did that by using the prototype concept and methodology. The prototype concept really is that to define a concept, you can either use necessary and sufficient conditions to define a group, a category, or you can look at the best examples of that category, or best examples of most prototypic features or attributes of that category. So using that, we want to generate features or attributes of Syrian refugees that Turkish people think that they have. So, so basically we asked a Turkish sample to provide us adjectives that come to their minds that describe Syrian refugees. And they provided hundreds of adjectives, but we sorted them into 91 distinct adjectives, such as immoral, ignorant, threatening, unreliable, but there were also positive adjectives, like resilience, for example. And then we asked a second sample of participants to rate the degree to which they think each of these adjectives describe a typical Syrian refugee. And here are the means. Losing a loved one got, for example, that is a high prototypicality rating, or needy. And then these are some of the ones that with low prototypicality ratings. So then what we did was we wanted to see who uses high ratings for positive adjectives. That is, who thinks that the more positive adjectives describe Syrian refugees. So basically, we took the mean for each participant, their mean ratings for all the positive adjectives. And as you can see, two important predictors were identified. Religiosity. Participants who were more religious were more likely to use positive adjectives to describe Syrian refugees. Now, this is a finding that is opposite of the finding everywhere else in the world for other stigmatized conditions, because religious people are usually more conservative and they are less likely to endorse positive adjectives applying to stigmatized groups. But in this case, we see the opposite in the Turkish context. And the reason for that is that Syrian refugees are Muslims as the rest of the country, one. but more importantly, it's a political issue as well. The ruling party in Turkey has religious roots, and they are, and the religious people vote for them. And this party was very instrumental in bringing Syrian refugees to Turkey. That's why religiosity predicts use of positive adjectives to describe Syrian refugees. And on the other hand, and negatively using negative adjectives here. Political orientation. So in this case, it looks like more liberal orientation is related to using fewer negative adjectives. So we have two predictors, religiosity and liberalism, that are related to use of more positive adjectives. Now, as I said, this is the conservatism findings are the same as we see overall globally, but religiosity findings are the opposite. So what we wanted to do then was, and İbrahim was instrumental in looking at this, the interaction of religiosity with conservatism. And as you can see here, by we, I mean İbrahim, found a significant interaction for both the use of positive adjectives as well as, is this, no, for positive adjectives. So, and he looked at it at this, whenever you have an interaction, you can look at it two different ways. You can have religiosity as the independent variable, and the moderator is political conservatism. And the y-axis is the same, prototypicality rating of positive adjectives. And as you can see, the effect of religiosity is stronger for people who are low on political conservatism. And that is mainly because if a person is low on political conservatism, then they, and also low on religiosity, then their prototypicality ratings of positive adjectives is low. But as religiosity increases, their positivity increases, their positive endorsement of positive adjectives. Whereas when political conservatism is high, then, or maybe this is the opposite, I did it wrong. Maybe liberalism is high. They use, so this is wrong, this should be liberalism. They start with high ratings on positivity, but it doesn't change with liberalism. All right, and this, so this is the interaction that I just talked about. And then İbrahim did a moderated mediation analysis, because then this use of positive adjectives to describe Syrian refugees had a negative effect on social distancing. So the more, obviously, the more positively you view Syrian refugees, the less social distancing you show towards Syrian refugees. And this moderated mediation model was significant, which is what this index of moderated mediation tells us. So now coming back to our main project, we actually worked on a grant proposal, and we just got a grant to widen the scope of our main project, which was good because we had not been able to start the main project due to COVID, but now we can actually make it a bigger project. We can expand the previous grant to include Afghan refugees and compare Syrian refugees with Afghan refugees, because we have a lot of Afghan refugees from Afghanistan here as well. And they're a little bit different than Syrian refugees. And now we can actually use a longer term longitudinal study design so that we can look at the effect of these different dimensions of stigma on depression with health service use as a downstream effect in this mediation model, where we will measure stigma at time 1, and then 6 months to a year later, maybe depression, and then at time 3, health service use. And then we will also be able to increase our sample size to 800 Syrians and 800 Afghan refugees living in Turkey. And we will actually open a new stigma center, start a new stigma center at Koç University in Istanbul, so that including scholars, experts, students interested in stigma and health, and not only related to living as a refugee, but there are actually researchers and NGOs and scholars working on stigma related to living with epilepsy, racial ethnic discrimination, stigma related to substance use, again, HIV and other chronic diseases. So we want to, within this and with the help of this center, we want to bring scholars studying these different stigmatized conditions. Thank you for listening. This is all we have, unless Ibrahim and Gulsah have something else to add. But we wanted to leave time to take some questions from you. Stop share. Okay.
Oh, thank you all very much. That's great work, and I love that you're looking both at the stigmatizers and those who experience stigma and discrimination. I don't know, I can kick us off with a question. I don't know if, do we have any other questions yet? Maybe we don't.
No, none have come in the
yet.
Q&A box. Yeah, so
right, okay, well, people should please feel free to ask questions. We've got time. And what I wanted to ask was a little bit more about mental illness stigma. And, you know, from Gulsah's presentation, I sort of understood that might also be a huge determinant of whether refugees and migrants utilize mental health services in this context. And so how are you measuring that, and how are you taking into account to try to understand what is really more salient, or how do these intersect?
Yeah, so I don't know if in this first study we are going to assess stigma related to mental health. But that's certainly a big issue. And especially, I mean, stigma related to mental health is a big issue anyway, but especially with this population, because as Gulsah mentioned, mental health problems are more prevalent in this population, and they also live in close proximity to each other, if not physically but psychologically. So there's, if somebody sees a shrink or anybody for a psychological problems, everyone will know. So that's definitely an important issue. And as I mentioned, poverty stigma is another intersecting form of stigma for this population, which needs to be examined. And maybe that will be our next study.
But can you not include the measures of these in the current study?
We could, but we have quite a few measures. I don't know if it will be too burdensome, but maybe Khalid can do it. We have a master's student who is actually going to do a related study. In addition to stigma, he wants to look at a concept called denial of identity. So if those Syrians experience that others don't see them as Syrian, the other Syrians, or whether Turkish people don't see them as Turkish. But now Gulsah reminds me that we actually have a few short measures of, well, why don't you speak up, Gulsah? We have measures of depression.
I wasn't so sure. We have the scale for poverty. Actually, to test the reliability and the validity of the stigma scale that we are building, we consider including some other indicators or the measures of the stigma, like poverty stigma and the mental illness stigma. So we already included those.
Excellent. Great. I think I see some questions.
So Anna is asking, what are some lessons learned? Oh,
and there's a previous question too, if you see that one.
I don't see.
How did you determine your predictors, religiosity and political orientation? Did you see any other trends, younger versus older, men versus women, about in attitudes toward refugees?
Okay, so I don't see that question, but anyway, yeah, we decided to look at religiosity and political conservatism because those are the ones that we see in other studies. Actually, we ourselves have conducted several studies, for HIV, for example, HIV stigma, and we did find again conservatism and religiosity, but in the opposite direction, as I said, both in Turkey and in the States. We saw those, and in the literature we see those as important predictors. In terms of gender, age and gender, I don't remember what we found, but Ibrahim and Gulsah are more familiar with those data. Maybe they will remember if we found something.
As I remember, we did not do any, I think, statistical analysis related to gender.
We did.
We did? Sorry.
Gulsah remembers everything.
Actually, we conducted.
We must have, because we certainly used them as control variables,
yes,
but we were
exactly.
not interested in them. But but do you remember the results?
I remember us controlling for gender and age, whether like the effect of religiosity and political orientation will still be there. But I don't remember exactly the results. Yeah.
Yeah.
So but we have them. We can look them up. Anna is asking, what are some lessons learned that could be applied internationally, including in the US? Lesson number one: don't try to do a study like this during COVID or probably any other pandemic. What other lessons did we learn, Gulsah and Ibrahim? Well, we are lucky because Gulsah has learned her lessons previous to this study, because she conducted quite a few studies with this population specifically. So she spared us from the pain of learning from our mistakes. But maybe she can still talk about some lessons.
After 4 years of like working with the refugee population, I still enjoy my misery in conducting research with this particular population. But actually, maybe related to the stigmatizers part, I can say that I can say something as a like lesson learned. We were expecting to see the different result when we take into account of political orientation, because in the European context, we see that conservatives are more likely to be conservative towards like welcoming the refugees, but we were expecting to see the opposite pattern here in our context because of the things that Dr. Turan explained. Like we share the same religious background with the Syrian refugees, so probably the conservatives would show some like positive attitudes towards like welcoming refugees. But actually, since we conducted this study with the student population, we just saw the similar pattern with the European context. Like the liberal orientation is kind of like more open to welcoming refugees. So actually, this was interesting for me.
But that was only possible when we took into account religiosity and even look at the interaction of the two, which provided a clearer picture, which you don't need in the States, for example, because they go religiosity.
They go hand in hand.
Yeah, go hand in hand.
As I'm involved in a study about COVID stigma in the United States, in Alabama, actually, and we are measuring both religiosity and political orientation, and I expect we'll see very different things than what you're finding.
So maybe that is one lesson learned, is that what you see in the States may not apply to other countries. So the context, obviously, to state the obvious, does make a difference, but you need to maybe predict what those might be based on the cultural context.
I was also wondering if you're measuring PTSD among the refugees, just again, because this is like a very traumatized population.
Yeah, we do. Maybe Gulsah will talk about it, because she measures it routinely, and she's really interested in that. So she can talk about it, but we measure it in this study as well.
Yeah, we included the indicator for PTSD symptoms, but it is not on the level of like diagnostic level, but on the symptomatic level, we included such measure. In our previous studies, actually, especially in my recent study, we use PCL as the kind of indicator of mental health, and we kind of like look at whether COVID-related factors are associated with the traumatic stress symptoms, and we saw that COVID-related resource loss, such as loss of economic capital, social capital, and social capital basically, are associated with the increased level of traumatic symptoms. So actually, it shows that COVID-19 is another kind of like daunting challenge for them, and it's kind of like exacerbates their pre-existing difficulties. So maybe as a future lesson learned for us, we need to be careful about the potential impact of COVID-19 on mental health. Probably they will experience or report a heightened level of mental health problems, including PTSD symptoms.
Great. What is the longest, like, I mean, for the refugees, like on average, how long have they been in Turkey? Like in some Gulsah and some of your samples?
If you're asking for Syrian refugees,
Yeah.
The kind of like, I think 11 years is the top that they can
Okay.
report, because the civil unrest, civil war has started in 2011, but for Afghans, it goes back to around like 1980s.
Oh, wow. Yeah, I was just thinking about the recency of the trauma, you know, would obviously have a big, or the recency of the migration. And I like your framework with the pre-migration, the during migration, and the after migration. Those are all contributing, I'm sure. Yeah, we were listening to a talk at Koç about someone who was talking about refugee camps on the West Bank, and actually some of those people their families have lived there for generations. So that was a completely different, you know, situation than these people who have experienced probably very recent trauma. So very interesting. So what are your next steps, Dr. Turan, in this?
To finish the darn project.
Finish the project. Okay.
Because of COVID, we've been, you know, waiting, and so we're really excited. But as I said, so we want to, so the Khalid, the master's student I mentioned, he wants to look at in depth in the identity experiences, that is, how do they experience their Syrian identity and their Turkish identity. So that is one of the next things that we want to do. And after that, I don't know, what do we want to do, guys? Ibrahim and Gulsah they're always wanting to do more and more, but you know, it's, I tell them, wait. What else do we want to do? We will have a lot of data from this study that will keep us busy for a while, but
I can also mention that we have 2 UAB students who are coming to Turkey this summer, Sebastian and Emma Kate, and possibly another one, Abraham.
Yeah, there's a one. Yeah.
Yeah, and are going to be working with us on this project. They're going to be doing some qualitative in-depth interviews with stakeholders around these issues, so we can get a perspective of people who are working with refugees and migrants in different settings, health workers, government organizations, NGOs, researchers, so that we can get informed by their perspective on these issues. So we're looking forward to them arriving in about a month and getting started on those interviews. Thank you. Just got a nice feedback from one of our colleagues. Thank you. And yeah, I think we're hoping for a growing program of research between Turkey and the United States and UAB, really. And we do have a memorandum of understanding between UAB and Koç University. And I think there are a lot of exciting opportunities.
All right, I don't see any more questions that are coming through. So just a reminder, this is recorded and we'll post it on our YouTube channel on the Sparkman page for anyone that wants to watch it later. So thank you guys again for being here and making the time. I know the time change can be a little tricky, so I appreciate you guys having time out of your evenings to join us. So
time for dinner.
Thank you so much. All right.
We'll
Bye,
see y'all
everybody.
later.
Thank you. Bye-bye.
Thank you. Have a lovely